Good afternoon and welcome to today's program titled The Use of Buprenorphine in the Treatment of Opiate Dependence. I'm Julia Brown, Associate Editor of Addiction Professional. Today's program is a Foundations Recovery Network webinar sponsored by Millennium Health. Thank you to our sponsor and to those of you in our audience for giving us your time and attention today. Before we get started, we have a few housekeeping details. Each window on your screen can be moved by clicking and dragging or enlarged and minimized by clicking the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. If you cannot see this area, simply click the red Q&A button. To download a copy of today's presentation, please click the link in the resources area in the lower left of your screen. If you have any technical issues during the program, please click the yellow help button to troubleshoot the issue. A special note about CE credit. To receive credit for today's program, you must click the green CE certificate widget at the conclusion of the program and complete the evaluation form. If you are watching today's program in a group, please download the group submission guide and program evaluation form located in today's resources list and follow the instructions. If you have any issues with this process, do not reach out to today's sponsor as they will not be able to assist you in receiving a certificate. Please note, CE credit is not available for the archived webinar. It is only available for the live event. Finally, you can also tweet during today's webinar via the Twitter widget by clicking on the blue Twitter icon at the bottom of your screen. Simply click the Post and Authorize buttons to log in to your Twitter account and begin sharing automatically at the event hashtag #APLiveWebinar. At this time, it is my pleasure to introduce our speaker, Dr. Richard Gracer. Richard Gracer, founder and director of Gracer Medical Group, has been a doctor for over 30 years. He is board certified in addiction medicine by the American Society of Addiction Medicine, a board certified in family practice, and also a diplomat of the American Academy of Pain Management. Dr. Gracer runs Gracer Behavioral Health Services, an innovative and comprehensive substance abuse program that stresses the reduction of cravings. Thank you, Richard, for taking the time to speak with us today. And with that, the audience is yours.
Thank you very much, Julia. And thanks also to the folks at Foundations who do just a terrific job, not only with education and with treatment, but also connecting people so well. So today we're going to be talking about how buprenorphine works and some of the clinical aspects, different types of patients, and some of the things you may or may not know about it. So some of the things I'm going to cover are very basic that most people may know, but I have to make sure everybody understands the basics. And then we'll talk about some other interesting things about opioid receptors and different patient types and people who may do better or worse with buprenorphine. Also, I invite you to, and I will make available a link to a copy, Kindle or a Nook copy of my book, A New Prescription for Addiction, which has a lot of this in it, although the book is a 2007 book and we're in the middle of revising it, so there are things obviously that are not there. The other thing I want to say is that this, of course, is not just a problem in the United States. This is a global problem, and the solutions have to be global. It is just something that is ravaging the world, and I think that it's a very important subject all over. The other thing that I talk about is the fact that it's an old problem. So this is a picture of Stonehenge. I think many of you have been there, you know what this is. And believe me, back in the days when Stonehenge was built, they were making alcohol beverages and having alcoholism and so forth. So there's always about 10-15% of the population from way, way back in the earliest civilization who have addiction problems for genetic and or psychosocial reasons. And we know also that addiction is a brain disease and not only a psychosocial problem. I like this slide a lot. this is from probably Wisconsin. If it were a California slide, he'd probably be drinking some kind of a microbrewery or some kind of wine, but it almost doesn't matter what you drink. So I'm going to, as I said, gloss over some of this stuff, but these slides are there for you, and I'm sure most of you as drug dependence professionals will understand most of this anyway, but basically it's an alteration of the brain chemistry, and it involves multiple neuronal systems, biochemical changes, and the GABA glutamate balance is very, very important in this. I'll go over that briefly in a minute, and also dopamine levels in various parts of the brain are very important in addiction. So the difference between somebody who's addicted and somebody who is just intoxicated is the fact that the brain doesn't come back to normal, what we would call normal, in an addicted or somebody who's drug dependent. I'm not, and when I use the word addicted now, I was thinking physical dependence, not abuse. And basically, if you look at this, this is the difference between having enough GABA, which is the relaxation neurotransmitter, versus glutamate, which is excitation. And what basically happens is that things change, and the GABA receptors, which are 40 to 45% of all the receptors in the central nervous system are GABA receptors, become physically altered. And the normal GABA, which is GABA aminobutyric acid, is the neurotransmitter in the brain that actually works kind of like Valium. And Valium and benzodiazepines work right on this GABA A receptor, and that is why they are so effective in relaxing us. But after a while, it changes, and it doesn't go back to normal. And therefore, when you don't take the substance, which is stimulating the GABA receptors directly and indirectly, you get into drug withdrawal and all the problems that are listed on the slide. Opiates themselves work in various places in the central nervous system, and most of us understand the VTA nucleus of the thalamus going to the nucleus accumbens, which is the place in the brain where we feel pleasure and so forth. And if there's not enough dopamine in the nucleus accumbens is when you get into some of the problems with drug withdrawal and depression. But you can see that opiate receptors are working not only very strongly in that area, but they also are working in many other areas of the brain which have to do with executive function and with, of course, pain sensation. That's where opiates do a lot of their work. So with that brief background, I'm going to start talking more about buprenorphine, which is the active ingredient, so to speak, in Suboxone, Bunaval, Zubsolv, and the generic forms as well. And if there are questions about the different forms later, if anybody has any specific questions, I'll be happy to answer that. But basically, they're all buprenorphine. The other point I want to make is that the naabt.org website is a very good website. It's a nonprofit that was started through folks at Yale, and there's a lot of good stuff for both practitioners, physicians, and lay public, and they do have a lot of very nice information there, and it's not biased, basically, although they are pro-buprenorphine treatment, of course. So let's have a look at the opiate receptor, the Mu receptor. So there's more than one type of opiate receptor. In fact, there are 3, possibly 4. And basically, when we talk about buprenorphine, we're going to be talking about 2 of these, the Mu and the kappa. So the Mu receptor is the opioid or morphine receptor that we all know and love. And the reason that I'm putting this in on the slide to start with, it's a pretty complicated, busy slide, is just so you get the idea that there is more than one little part. It's not an on and off switch. It's a very complicated type of receptor that can be affected by several things at one time, and certain things can affect it more than others and in different ways. So it isn't one size fits all. Some basic terminology that we talk about when we talk about opioid receptors or any receptors have to do with agonism, partial agonism and antagonism. And to understand that just really briefly, and this is the basic stuff I was talking about, the fact that a receptor has what you can see on the bottom says affinity zone. In other words, is that something that, or a substance something that will fit in? Affinity means it likes it, and so it has to fit. And then the top part means activity zone. What does it do when it gets in there? So basically, heroin is a full agonist. So an agonist makes the receptor active. So heroin, obviously, oxycodone, oxymorphone, Vicodin, which is hydrocodone, and all the other ones, methadone, all work as full agonists, meaning that they get in, they have an affinity for the receptor, and they are active in the receptor. On the right side, you see naloxone, and we'll talk about that a little bit at the end because there's some new things about the use of naloxone that are very important for public health. But that's an antagonist. So what it does is it fills the receptor, you can see the bottom there, but it doesn't activate it. So it will take an agonist that's in there, and if you give enough of the naloxone, there's a lot of it, and it will drive the agonist, the heroin or whatever, off of the receptor and block the receptor, and then then the receptor stops being activated, and the person either wakes up if they're overdosed or they go into drug withdrawal if they have a physical dependence problem. Buprenorphine, by the way, Tramadol is another medicine kind of like this, doesn't do the same thing, of course, is a partial agonist. You can see that the top is sort of cut off there, and so it does some things, but not the same as the full agonist. And as I said earlier with that other slide, it's a complicated receptor, so all the agonists don't do the same thing either. That's why some people tolerate certain medicines and some people tolerate other medicines. So looking at the Mu receptor again, I want to show you a little bit about what buprenorphine kind of does in the receptor. And I'm going to go through these fairly quickly, and I've got a lot of slides to kind of show what happens with this. I don't want to delay too much on this. So the opioid fits right in, and the buprenorphine gets in there, but it is smaller in a sense, and it doesn't affect it quite as much. So there it is, the opiate right in the spot, and you get the maximum effect. That's the agonist, and there's no withdrawal, and the pain and all the rest of the effects are present. But with buprenorphine, it doesn't really fill it. So it does some of it, but not the rest of it. And so therefore, you don't get the same action as you would get with a regular type of full-bore agonist opiate, such as all those medicines that I listed earlier. It's an imperfect fit. Because it's an imperfect fit, it has certain things that are good about it. One of these things is that, and this is a dose versus effect type of common diagram, that as the dose goes up towards the right, with a full agonist like methadone, heroin, any of the ones I listed, you can see that it goes up, 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 eventually get respiratory depression, and you die. Partial agonist, like buprenorphine, only goes so far, and you can see that it sort of goes into a flat phase, and that's called the ceiling effect. And the ceiling effect is a protective thing, but also tells physicians using more than a certain amount of buprenorphine is probably not going to really do anything more. And if people are getting these prescriptions, these medicines may be landing up in hands that they're not supposed to be in. So limiting the doses to things that are reasonable is very important. But there's another point, and I'm hoping the next slide will show it. Okay, I'm going to go back over to the previous slide. If you are drinking a lot of alcohol, if you're using solid dose of benzos such as Xanax, that type of thing, lorazepam or Ativan, Valium, above a certain amount, the ceiling effect is unroofed, and you can die from that combination. So combining these medicines or these other substances with buprenorphine can be dangerous if the person takes an overdose, in the sense they keep pushing the dose, or if they're taking a lot of the other substance. That's just like anything else, and it's something I'm sure we're all familiar with. It doesn't mean that if somebody is under the care of a physician. They're taking carefully controlled lower doses, proper dose of buprenorphine, and they take an occasional benzodiazepine from their psychiatrist, that all of a sudden they're a bad person, they're going to die. That's not what it means. But what it does mean is that if you're taking this stuff and you take too much, you are vulnerable, and it's certainly not a good combination except under very strict medical circumstances and control. So just talking about the opioid receptors, and just thought this would be interesting. And again, this is not super important, but there's Mu receptor has got more than Mu1 and Mu2, but the different parts of the receptor do different things. And down below it, we talk about the kappa receptor, which is an opiate receptor, which is extremely important to understand the function of buprenorphine. And you can see that it does other things, and that when it goes into when it gets stimulated, you do get analgesia, especially spinal analgesia, but people start feeling bad. And if you take a look at the reactions, dysphoria, anxiety, and so forth, they're very similar to post-acute withdrawal syndrome. And what happens, and again, you know, this is something that naltrexone or naloxone, which are the blockers, we talked about the antagonists, tiny, tiny doses block the Mu1. So we sometimes even use this in order to block some of the side effects of opiates, including tolerance. We're using tiny, tiny doses, microgram doses, and it seems to actually help it. But what happens with the kappa receptor is that in withdrawal, the Mu receptor is under-stimulated, so you get all these side effects and problems, and the kappa receptor actually goes into overdrive, and you get some of the things that were listed on the previous slide. Buprenorphine is very powerful for antagonizing this and decreasing that stimulation. So this is something which we use, or most physicians may or may not understand that this is what's going on, but this is the reason why people have very, very important and major effects from very low doses of buprenorphine. And maybe one reason why it's so hard to get off buprenorphine is because it's blocking kappa at very low doses. So this is sort of saying what I just said, and giving buprenorphine, important to know, buprenorphine, if you replace an agonist with buprenorphine, you're understimulating the Mu receptor. You're going to go into drug withdrawal. That's called precipitated withdrawal. It can be very, very severe. And also, that slide says that the buprenorphine is very sticky. And the word sticky means that it has a high affinity and it will push off morphine or some of the other opiates so that it will preferentially stimulate the Mu receptor. And therefore, if you're on some of these other opiates, it will understimulate it. And that's why people go into withdrawal. And it's sticky and it likes to stay there. So it gets rid of the full agonist preferentially and then doesn't do quite the same job. So that is very important, and as I mentioned, it's a very powerful antagonist of the kappa system, which is an important thing. So let's have a quick look at this opiate system. Basically, and I'm going to go through these. This is in my book, and I'm going to go very quickly through it. I'm trying to not spend as much time on this, but I think it's really important. So this is a visualization of the area that the opiate receptors in the brain. It's sort of like a meadow, you might say, or something. And the endorphins from the brain up there on the right are being poured out, and they fill these receptors to a certain amount. And then, of course, they fall off the end, and that's why we have to continually have more replacement of these because they're metabolized and changed. And it shows that the Mu receptor, Mu opiate receptors, an arrow there, is a little larger than the kappa. This is my visualization. Also, there's a sensor that regulates the production so that when this area has got enough stimulation, the body turns off production of endorphins. It's a negative feedback system like the thermostat in your house. Got enough? Don't make more. Now, on the left, it says there's no opiates. That little horn thing on the left tube is really where you would take if you take oral opiates or something. So here we go, and now somebody is taking an opiate. You can see a lot of these big, heavy black balls are in there. They displace the endorphins. They are heavy. Therefore, the sensor says stop making endorphins. And they're so heavy, they create their own holes. You get new holes in the receptor area. And that is what we call upregulation. In other words, the point being that as you take more, this is the physical changes that you get in the system. And you can see they kind of fill the kappa receptors. They're a little big for them, but they do fill them, and there's a lot of them. Not a problem. And then you stop taking the stuff, now you don't have anything coming from the endorphin, you don't have this, you got a lot more receptors, you're in trouble. The next thing that happens in this is that we start someone on buprenorphine. So what happens is, you can see on the left, there's some little, that's the buprenorphine of the little balls. It's just the way I drew them. And basically it fills all the receptors, and it can make you feel very good. It's very good for the kappa. They're not very heavy. The meadow or these holes, all these extra holes can start healing, especially if you're on lower doses of buprenorphine. And the Mu Receptor system is sort of, rehabilitated, and eventually, if you're not using really high doses of buprenorphine, some of your endorphins are coming back and looks more normal. But the kappa really is really filled by the buprenorphine preferentially. And so that, as we get into very low doses of buprenorphine, can be a problem where the kappa system still is modified by the buprenorphine. Now, this is a slide I've used for a long time. It's a 2003 slide. But I have to say, and I didn't get a chance to put this in the presentation, that recent studies again and again and again show this. This shows people on buprenorphine versus people who are off buprenorphine on how long they stay clean, basically. And again and again and again, we see this exact graph. Walter Ling did a study at UCLA a couple of 3 years ago. They basically treated people with buprenorphine in their clinic for 6 months. They got basic counseling and so forth. And there were a very significant number of these people were clean for that time period. Of course, nothing's 100%. They then tapered and stopped them at 6 months as part of the protocol, and there was a 90% basic recurrence rate at a year. We see this almost every study. With methadone, the same thing. People have been on methadone a long time. So we know that people who are on opiates for protracted periods, who've got really adapted brains, have very long post-acute withdrawal, which is the ongoing problem of just feeling bad even though you're off the stuff, and eventually they fall off the wagon and they start using it again. And this is the public health problem emergency that we have. It doesn't seem that despite all the good work that all of us do in my IOP and your programs that you work in, it doesn't mean much if the person has got an altered brain, it isn't doing very well. So that means that we have to treat people multifactorially, including depression and a lot of other problems, in order to help them feel well so they're not going to go back and use. And this is the challenge that we all have, and this is one of the reasons that we were talking about earlier, that they are now, the Obama administration now is lifting the 100 patient limit for people who are board certified. I think it hasn't happened yet on how many patients you can treat with buprenorphine, because the bottom line is that this saves lives and this makes the outcomes much, much better. But there are different kinds of patients, and some should be on this and some don't need to be on this. So let's go on to that side of it. Very quickly, this is one of my favorite pictures that I've taken. This is in Red Square, St. Basil. Just because it's pretty and it's a segue. It's a very interesting place. I visited Red Square a couple of years ago, and it's a lot smaller than I thought it was. But anyway, so what is detoxification? This is, again, Walter Ling's an eminent addictionologist at UCLA. And he says detoxification is good for a lot of things. Staying off drugs is not one of them. So detox is not complete treatment. It's fine to get somebody off drugs. It's a good thing to get them off the drugs, of course, but it doesn't stick unless they get treated. And part of that treatment for a lot of these people, unfortunately, has to be replacement therapy. And the two replacement therapies that we have available now are methadone and buprenorphine, with buprenorphine probably being a lot more healthy for people in the long run. But those are what are available. And again, study after study after study shows dramatic differences between people treated and folks who are not treated with these types of treatments as far as recidivism. And really, our society needs to cut back on this. It's not good to need to take buprenorphine or methadone. That is not a good thing. That is a very negative thing, but better than being on heroin. And that's sort of the way, and all the ramifications that come of it. It's not the subject of my talk today to go into all the bad things that happen because of these drugs, but we all know what they are. So let's talk now more about the specifics of using it. So the withdrawal syndrome for Mu receptors are what we all know and love. It's the COWS, right? Clinical Opiate Withdrawal Scale, and those are the things that we see in should all be familiar with. But kappa is different, and when kappa goes into overdrive, people feel like this, which is difficulty. And this is what post-acute withdrawal is, if you think about it. And that's what my opinion is, that a lot of post-acute withdrawal, this is an opinion, this is not 100% fact, a lot comes from kappa problems. We're learning more and more about the different receptors and developing medicines that hit the receptors various ways. And so I think that we'll be seeing some new medications coming out, not just for addiction, but for depression and anxiety that will be based on that. So over time, this is, again, my thinking. This is not from anywhere else. This is from my own deduction and experience. I have separated in my own mind, and I think it's a useful way to go about it, different types of patients who use buprenorphine. So let's go through them so you can see who they are, the pre-existing abnormal kappa system. I'm going to go through each one. So I'm not going to just read them off. But they are different, and telling the differences between them may be very difficult. And I'll go through this fairly quickly. Again, hopefully the slides will be available to you as an archive. I also have a handout which I can make available, a PDF file, I believe, which has got all this written out and so forth and explained. But basically, the first type is some people don't have a normal kappa system. These are maybe your bipolar patients. You know, you ask a question, how were you before you started using opiates? Well, I was a mess. I was always anxious. I went to different psychiatrists when I was a kid. I tried all these medicines. Nothing worked. I don't know. Finally, somebody gave me a Norco, or I got a bad leg and the doctor prescribed. It's the first time I ever felt normal in my life. And I just was great. So I started using it, and of course we know what the consequences of using those drugs are and all the problems that roll in later. But that is the history. And these people may very well have problems with their kappa system. They may also have undiagnosed and untreated bipolar, other mood disorders that you have to look for as well. So what happens with these folks is that you don't have any problem getting down to like a 0.5 or 1 milligram a day on buprenorphine, but then they start to go back to the way they felt before. And certainly if you've been abusing drugs, your brain isn't going to be better than it was before you used drugs. So these people are going to go back to at least what they had before, and that you have to be very vigilant to treat these, be aware of it, and be aware that the treatment for this may be very low doses of buprenorphine. I have a series of patients referred by psychiatrists with refractory depression. A couple of these people have had ECT even and so forth, who on various doses of buprenorphine lead normalized and feel fine. We go off, we try to get them off and on. They do not have actual opiate addiction as their main problem. And so, of course, I don't use this treatment on everybody who walks through the door, only referrals and people. Most of them have got this situation where they've been addicted and been on opiates for the reason I explained above. So I don't really have any ethical questions about just putting them on buprenorphine instead or low doses. Obviously, it'd be nice to get something that wasn't habituating that would do this, and this is what some of the drug companies are working on now. And we're even, some people are using a little bit of naloxone or naltrexone with buprenorphine to block the Mu receptor and preferentially hit the kappa receptor. Those are studies that are ongoing. There's no real data on that yet, and I don't have any specifics on it. But that's the kind of thing that's going on. So it's really hard to tell these people from people who are genetically vulnerable, which are people that, these are the 20% of the population who are vulnerable to alcohol and so forth, and they don't have a drug addiction or a mood problem, but they get some kind of narcotic after surgery or whatever, or somebody tries it, just like smoking, you know, they try it as kids, and those who are susceptible can't stop, and that's what happens. And then all of a sudden they are very vulnerable to this physical dependence, and they have very, very serious trouble getting off of it, so we get referred, and then we try to get them off as quickly as possible and get them off buprenorphine as soon as possible, just to get them through it, because I don't want to get the kappa downregulation problem where all of a sudden you're going to have a chronic ongoing post-acute withdrawal from that. And that does take a little while to occur, and I think that is a problem with buprenorphine, that the kappa system gets altered. That's my opinion on why it's so hard to get off. But these people, obviously, you just want to get them off and get on with their lives. They don't really have psychosocial issues as much. The third type of patient, if these are people who've been on heroin and methadone for a long time, they never do, I'm going to say never, that's not a bad thing to say about people, but they hardly ever really do well off of something. And these are the people that may have damaged their own brains from doing this, they may have done other drugs, but these are the ones that are the chronic recurring people, high-level psychosocial problems, and these are the folks that probably need to be on buprenorphine. These are the ones, the 90% recurrence rate type people, that no matter what you do, their brain just isn't going to be normal, and you can get 5 or 10% of them through it, but most of them are going to recur. So after you see this kind of person again and again, how many times do they go through the revolving door until we realize that they need to be on some type of replacement? And I think that is the type of person, and it's a very, very common kind of person in our society, unfortunately. And these are people that probably need to be on buprenorphine maintenance or even methadone. Because of the laws, I don't use methadone that much. I do use it for pain management. It's a good pain medicine. But, you know, I've got patients who have been using methadone for years for pain, quote unquote, and I really know what's going on with them, and they just don't ever seem to be able to get off. And so that's somebody who probably needs to be on it. And you have to be able to say and tell, okay, you know, maybe there are people that we have to admit need to be on this stuff, and that's what they need to do. It's certainly really good to try to get them off and work on it, but after 2 or 3 times, what are you doing? You have to ask yourself that question. So then the type 4 is people who have been on this for a long time, and they've adapted their system because they're on it. In other words, they're not people like the first one who just got on something short term, but they've been on this for a while. They don't have any prior history of mood problems. And they are the ones that are really hard to get off the buprenorphine. Micro tapers we're doing compounded troches at very low doses. We're using Butrans patches now to get to the much lower doses. This year coming up, 0.8 and 0.4 milligram doses, I believe, will be FDA approved for pain management, which is the original use of buprenorphine. And parenthetically, buprenorphine is something like 100 times stronger than morphine at low doses for pain management. It started off as an injection called Buprenex for post-op pain. But anyway, so these people also, it's hard to differentiate between somebody who never had a normal kappa system and someone who had it adapted. It's hard to know. These people, it's worth really trying to get them off, but after a while, I've had one patient, for example, who I did get off, nice middle-class lady, she's about 45 years old, and she did. She got off, and 4 months later, 4 or 5 months later, she came back and said, I can't do it anymore. We tried all the different medicines, and I use a lot of amino acids and other nutritional things, which we can talk about at another time, and it just didn't work, you know. And so she's on a low dose of buprenorphine, leading a normal life, and I'm not happy with it. She's not happy with it, but, you know, after 4 to 6 months and still feeling terrible, I don't know where to go with it. She did not go back to using. So my patients in general don't go back to using. They come back and we get them back on the medicine if they need to be. Or we try something else, you know, do a lot of other things. All right, then there's people with opioid tolerance and dependence. They have legitimate pain issues. And these are people that really have this tolerance, but they need increasing doses of opiates. It isn't working for them. They are out of control in various ways, but they have legitimate problems with pain, and they probably need to be on something. And as I said, buprenorphine's original use is for pain and very low doses. So somebody who's on 80 milligrams of OxyContin, say 4 or 5 times a day, may land up being on 2 to 4 milligrams of buprenorphine a day and have almost no pain. So it's hard again to tell, are they a type 4, are they a type 5? The difference in my mind is that they really have a legitimate reason to want to take something for their pain management. And, you know, they've gotten to a box maybe taking too much opiates or whatever, but that is a very common pathway towards drug abuse. And then if you take them off of everything, now they still have their ongoing severe pain problem. And what are you doing there? Well, that is, again, a judgment call. And but I'm just telling you that in my hands, very low doses very often do it. And the other thing about buprenorphine and methadone, this is listed in this slide. And what it says is that methadone's got like between 24, 48, even longer, depending, it's variable, half-life. And that is something which is a benefit and a danger with methadone because, of course, has a slow onset, and that's why people who aren't used to doing methadone, drug abusers, they take a little more, they don't get high, take a little more, and then later on it catches up, they don't wake up the next day. And this is one of the most common causes of drug overdoses and death is from methadone use. Buprenorphine doesn't have that particular problem with it, except if you're abusing other drugs with it, as we talked about. But it also has something where if you're going, and this is the point I'm making with this, that methadone for legitimate pain patients, even though it has this long half-life, you have to use it maybe 2 or 3 times, 4 times a day. For some reason, it seems that the pain control part doesn't last half-life as long as the actual drug in the system. And the same seems to be true for buprenorphine. So usually it's 2 or 3 times a day for pain, but maybe less for some people. And I think that that's another area, that's a gray area, it has to be the physician and patient getting together. And the last thing I want to mention is Tramadol. Tramadol is billed as an opioid or sort of a partial agonist, and it's safe and it's not addicting, which is a lie. It is addicting, not as addicting. It's not as easy to get addicted, but you can do it. Veterinarians have it. I've had a couple of veterinarians and veterinarian assistants who they have it by the thousands of bottles of it in their vet clinic, and a lot of these people get on it. And it seems like, also by the way, Tramadol is an SSRI like Prozac. It's a serotonin reuptake inhibitor. It's a very good antidepressant. So they try to get off, they get depressed. You may have to put them on something for a while to bridge. And also extremely low doses of buprenorphine seem to work very well for this, and because it's a partial agonist. And that's the only thing I can say is to describe it. I don't have any more, but I'm aware of it, and if I see people with these problems, then I go on with that way. So how do we get people off? I mean, I think this is a very important issue. This is something which is probably up front and center for most addictionologists. It's certainly one of the things that is brought up by people who believe in only abstinence-based programs as a negative about using buprenorphine. There's no doubt that a lot of people on buprenorphine probably don't need to be on it, and that people getting higher doses are giving it out, and there's diversion. All this is happening. And also, why do people need to come see a doctor and pay various amount of money, depending if they have insurance or not, or if they're getting ripped off by some of these buprenorphine clinics which don't really do therapy, and we all know they exist, and I condemn them as much as anyone else. We don't do that, of course. But what do? You pay money every month. It's expensive. You're hooked on it. It's better to get people off it. It is much better for people not to be on it, unless they have this post-acute withdrawal, these altered brain problems, this mood problems that we talked about, which lead to recurrences, or they just keep getting back on the drugs again and again for whatever reason. I mean, then they need to be on it. So what do you do? And these are the questions I ask. And of course, we talked about the different patient types. Being aware that those patient types exist gives you some guidelines. It's hard to tell between the types sometimes, and I don't really know. And the question is, how long is long enough? Don't know. Shorter is better. If you're going to try to get them off, do it early, because we know the kappa system can get adapted by taking, this is again my idea of why it is, buprenorphine for a long time. That's also why people can get down to very low doses fairly easily of buprenorphine, can't get off that last little bit. I believe it's the kappa situation. But what do you do? I mean, how do you actually go about it? And it ain't easy, as I said. So we talked about Mu Receptor. It's a partial agonist and very sticky, and it's an antagonist, very effective at low concentrations, and that's something that I've said before. And this is another visualization of this. This is a logarithmic scale on the bottom of buprenorphine dose. So it goes from 0.1 all the way up to 16, which is the doses and the average withdrawal symptom. And I'm just showing here, this is not exact or scientific exactly, but it shows that as you're coming down off of buprenorphine, you get withdrawal like, between 8 and, 12, 16, and then it kind of goes down. And then what's happening is it's starting to go up there by 0.1 to 1, and that is the kappa receptor getting unblocked. So you're getting 2 types of withdrawal, and they're different at different doses. This is just an explanation of what I've told you before. It's sort of an illustration. So what do you do? Well, as I said, it's pretty easy to get down to about 4 milligrams. You just taper people. If it's early, if you're just using it to detox somebody, a month, maybe less, 2-3 weeks. You just do it, and it has a long half-life. It's very good for withdrawal. It cushions the withdrawal. It's an excellent thing to use for detox. But I'm talking now about people who've been on it longer, and as I said, even slow tapering may not work. So we are using the Butrans patch, which is buprenorphine. It's a weekly patch. It comes from 5 micrograms to a 20 microgram size. They may be going up to a 30 eventually. It's for pain management once a week. So it's really nice in the sense that if you look at the blood levels, you look at the levels that actually are attained using these patches, they're similar to quite low-dose buprenorphine, which is similar to what we're finding with this kappa business. And so you can just gradually get it down. Also, take note of this, because if you put this this website, helpmegetoffdrugs.com, unless you really get it right, for some reason the search engines aren't too good on it. But this is a very good website, helpmegetoffdrugs.com. You go to that, and they also have a way of cutting back, and it's a schema of what to use and how to use the strips and whatever. And I took a very close look at this website, and they actually scientifically are good. I think it's valid information. Sometimes it's not as easy as they think getting off, and some of the other Butrans and some of the other ways might be helpful or better. I very often will give people, sometimes need antidepressants to help them get off, right? They may have a problem. And we also very often will use nutritional supplements and other things that can help cushion it, along with, of course, a lot of therapy and support, because it ain't easy. And this is something I think that is up. Okay. There was something, a slide was out of order. All right, now this is I believe my last slide, and I really wanted to get through this fairly quickly. There's so much more material that I could go through, but I just get the idea of what I'm saying, I want to tell one story, then I'll describe the slide. I was at an FRN conference, a weekend of some sort, a couple of years ago, and there was a patient we were going to get from one of the FRN sites, transferred, and we have an outpatient thing, and what happens is that most of the major residential programs, like FRN's programs, if they have somebody who's in our service area, which is East Bay of San Francisco, Contra Costa County, they very often send them to us. So we kind of get the handoff, and then they come into our IOP. As much as we refer to them, of course, I just sent somebody today to Michael's house this morning, as a matter of fact, before I got on this, who obviously needs a residential program so I can get control of what's going on before we can work with him on a long-term basis. So this person was going to come, and he'd been a heavy-duty heroin addict, and the reason he was in rehab, so they run out of veins, he was going to die, and he lived fairly close to us. I mean, we're talking really bad heroin addiction problem, and they detoxed him, abstinence-based. It is now 2 or 3 weeks into it, and the guy is going to sign out AMA. He's absolutely out of control. There's nothing they can do, and we were about to get him. So I then talked to one of the head people over there, who's an excellent person, by the way, and they said, well, you got to put him on buprenorphine. I mean, he's going crazy. You have to. And that's the treatment for now. Then I'll deal with it when I get him, and we'll see. And she said, I don't quote believe. No, I'm not a buprenorphine. I'm not a buprenorphine person, is what this person told me. And I said, well, I'm not either. I don't have that problem, but some of our patients are. And that was the point. So I called them, and the doctor in charge said, well, I don't know if I can give them buprenorphine. I used to use it all the time, but here they don't like it. And I said, well, if you don't do this, you're going to lose this guy. So he did whatever he had to do. He put the guy on the buprenorphine, and that afternoon he's back in group, feeling great, everything's okay. And we eventually did get him. And to be honest with you, he was a really tough patient. Really tough to get off, and he's in the wind. He didn't do that well. He's a very high-risk, terrible patient, but without using buprenorphine, there was no chance of treating him. I mean, he was on his way home to score, out the door. At least we had a chance with him for a little while, and of course, he wasn't really ready. So it's not a panacea, of course. And, if you have dirty urines and all that, we have to deal with it. Now, I'm just pointing that story out because, therefore, I'm not a buprenorphine person either, but some of my patients are. So to have an open mind. Even Betty Ford and Hazelton have revised their protocols completely now to include the use of this type of medication. So those of us who are brought up in a sense in the AA and all the rest of that, where drugs are bad and whatever, have to recalibrate. It's time to recalibrate your thinking and realize that although buprenorphine is a double-edged sword and all the things I talked to you about, it is vitally important for the social well-being of our country, basically, too. Look at the problems we're having. Addiction problems are like over $500 billion a year in our country. We could empty out the jails, so to speak, if we didn't have this problem, right? That's another talk, too, about how to solve the drug problem, because we've lost the war on drying up drying up supply. So we have to work on the demand side of it, and that's a whole other story I won't get into now, but I'll be happy to talk about it in the future. All right, last slide is something that really hits exactly what I'm trying to say, and usually if I have a live audience, I'm telling them, what is that? Nobody knows. One person raises. Well, I'll tell you what it is. It's the Sphinx in Giza. That is the Sphinx, but it's from the back. So I never knew that, like, the Sphinx really was right by a major city. You can see it's not like in the middle of the desert or something. And I never saw it. I didn't know what it was. So I used this slide in almost all my presentations to ask people to be willing to look at the same old stuff they always see from a different point of view, sort of like reframing in CBT. That's what I'm asking you to do. Learn more about this medication, learn its uses, ask questions. A lot of the physicians who use this don't even know what kappa is, I have to be honest with you. There's a lot of ignorance out there. Most of the addictionologists and people that will be working at foundations obviously know what they're doing, and they know all about this stuff. So I don't think that we should be doctrinaire. I think that we should be open and welcoming of all these new treatments, because we haven't really done a very good job. Look what's going on in our society. That's the proof of it all. We need to, of course, have more availability and all the rest of it, but this is also an important area. Thank you very much, and I'm going to leave it for questions at this point. Julie, you there?
Thank you, Richard. Yes, I'm here. Thank you so much
Great.
for a very informative presentation. Before we get to the Q&A portion of today's event, I would like to hand things over to Melanie Melcher from Foundations for a few words from our sponsor.
Thanks so much, Julia. Here at Foundations Recovery Network, our grassroots movement called Heroes in Recovery has a simple mission: to eliminate the social stigma that keeps addicted individuals from seeking help, to share stories of recovery for the purpose of encouragement and inspiration, and to create an engaged, sober community that empowers people to get involved, give back, and live healthy, active lives. Join us in this mission at our 6K race series at these locations across the country. As a thank you for your attendance today, please enjoy the discount code Webinar 2015 to register for any future 6K event. Back to you, Julia.
Thank you, Melanie. We've already had a number of questions from the audience come in. However, we would also like to remind those in our audience to use the Q&A widget below the slides on your screen to submit a question at any time. Our first question is, Richard, you have touched on this briefly throughout, but could you share your opinion on using buprenorphine in low doses as an SSRI substitute for a person who would be categorized as a type 1?
Okay. First of all, yes, of course. Well, I think I've been alluding to that, where the drug companies actually are trying to find substances that aren't habituating, aren't changing the actual structure in the brain the way that buprenorphine does for this purpose. And I think that by talking to our patients and asking the questions, okay, what were you like before? What happened? I mean, people don't even ask about that. You can get a hint on whether or not this is going to be helpful. But I would caution people in just using this as a substitute for Prozac or something, in that it is not an innocuous substance. But I think that I've seen so many people with terrible anxiety problems and really bad depression who feel absolutely normal. As I said, I have a series of people. One, for example, is a gentleman who had a meningioma removed, an engineer. He's about 60 now. And he went into a deep depression. It's organic, probably from the surgery. I mean, he was sitting crying for 3 years. in the home. And literally, it was unbelievable. They finally sent him to me, and he is now on a fairly sizable dose of buprenorphine. He had some pain issues, needed joint replacements and stuff, and he's basically a normal guy now. So it is very important to look at that, but very carefully.
Okay, great. Thank you. Here's another question. This person works in detox, and just from their experience, the combination of Subutex and Ativan seems to cause sedation. And the question is there a better combination for alcohol and opiate withdrawal?
Okay. First of all, if somebody's in alcohol withdrawal, what you want is sedation for a while, right? I mean, we know that withdrawal from, and I'm sure everybody knows this, but I have to say it, withdrawal from opiates, unless you have a heart attack or something like that, is not deadly. You just feel like you want to die. It's horrible, but it's safe. The people will Jones, and eventually they'll be okay. They may have post-acute withdrawal, but they don't land up and die. Benzo withdrawal and alcohol withdrawal are killers because of seizures and so forth, DTs and alcohol, and seizures and death, particularly with benzos. And just parenthetically, we can talk about benzos another time too. That's harder to get off of than all the rest of them almost. I mean, that takes a year or two to get off of. Having said that, Ativan, lorazepam, is commonly used as a short-acting benzodiazepine in alcohol withdrawal. It is safe to use in moderate doses with reasonably low doses of buprenorphine. People who are getting those combinations in drug withdrawal need to be monitored in a hospital type or clinic type setting where they're being carefully monitored. So while using Ativan in high doses chronically and then taking a bunch of Suboxone or whichever one you're using, buprenorphine, can lead to serious problems and death, that particular combination doesn't trouble me if it's being done by a physician under direct observation. And in a sense, you want to be sedated for a couple of days. Now, if someone is past that and they're over-sedated, then you stop the Ativan, which you get rid of it pretty quickly. For people that are not on buprenorphine and you're going to use oral, like a do it at home or something like that, we tend to use Librium, chlorodiazepam epoxide, or even Valium, which are longer acting because we want to have a smoother type of dose curve.
Great. Here's another question. What do you recommend as some best practice guidelines for the induction of buprenorphine?
Are you talking about like the question is how you actually start buprenorphine? I'm going to answer that question.
Yes.
Okay. I didn't go into that. I have a whole set of slides on that because, what can you do in an hour? The answer is, traditionally, what we say, and I think this is very important, is that you want somebody to have like a 12 or a 13 on the cow scale. They should have some stomach cramps or some problems when they're getting on it. Then you look at the dose, how long they've been using, how much they're using, and if somebody's been on pretty low doses, some people just are, some of these people like the type, I think it's type 4, where their brain is just so sensitive to it, that you can use a very tiny dose of buprenorphine. I'll use 2 milligrams, something like that. I don't use more than 4 milligrams initially because what can happen is, especially some of the opiates still in the system, that they feel great in the morning and they're barfing terribly in the afternoon, and eventually it takes a couple of days to get on. So I tell people to go low and slow, and I will, rather tell someone, look, you'll be in some drug withdrawal for a day, so we're giving them very often a low dose of benzo, again, very low dose, appropriately, very short term. And we're not giving them very much. They're not on high dose of buprenorphine during that time either, right? They're on very low dose under supervision. Or just put up with it, for an extra day. Clonidine is very good. We use a lot of clonidine, which is blood pressure medicine, which blocks the locus coeruleus action where you're getting a lot of sympathetic nervous system stimulation. So just go low and slow, and make sure that the person is in enough drug withdrawal to be sure. Another way to do it, and this is one of those settings that don't try this at home type thing, is if somebody's on a real high dose and just never going to get off, you can start with really low doses of buprenorphine and gradually increase them And then after they're up to a little bit, the person can basically just get off what they're on. You can sort of like get it, it's sort of like going in from one boat while stepping out of the other. There are other techniques and guidelines which I can't go into now.
Okay, great. Another question, would you add 12-step meetings as a needed transition off of buprenorphine?
Well, we use 12-step meetings in our programming. We have our people going together to 12-step. I think 12-step, you know, it's a very important, ubiquitous type of support system. So I have everybody try it. Some people like it, some don't like it. The problem with 12 steps for me is that it's, quote, the only thing that works, unquote, and it's not. And it's not enough for most people alone. It just doesn't do it for most people. If it did, we wouldn't be having a drug and alcohol problem now, right? So, you know, we have to, but it's extremely valuable. And the fact that it's free, that it's there, and they're very good people who work very hard, sponsors, to help people, I think are valuable. It's a very valuable thing to do.
Okay, great. Another question. What would you say to an abstinence-based treatment professional if you wanted to invite them to at least learn more about medication-assisted therapy?
Well, I think the start, if you're talking about a physician, there are buprenorphine courses. They could start, you know, reading the literature, which is just replete with, I mean, even the therapists. I mean, I mean, after a while, you got to believe it. You know, when you look at these statistics, and start learning about, you know, and looking at their failures. I mean, anybody's in an abstinence-based system. Listen, I've had a lot of failures too. You know, when we look at what did we do wrong, what could we do better, and they need to just start looking at it. But to start learning, there's a buprenorphine course. I'm sure that and I don't know this for sure, but that the MFT folks and LCSW folks probably have seminars and so forth that are available to teach about this stuff. And just listening to what I'm saying now is a good start.
Great. Another question. Have you seen an increased experience of anxiety with buprenorphine with some of the patients? And if so, do you have any treatment response to that?
I don't know that I can say that buprenorphine has caused anxiety in any of my patients. That doesn't seem to be something that's very common. It's possible. But what you see very, very commonly is the fact that the anxiety is the driver for drug use. And if you look at drug withdrawal and for alcohol, benzos, of course, and opiates, what happens? People get anxious, and that's the thing. And this underlying anxiety and low level, I don't feel good thing is what causes recidivism, it causes recurrence. So I see it a lot. Now, having said that, you know, there are a lot of treatments medically, not just psychosocial, but we try a lot of things. We stay away from the benzos. Although, you know, to be honest with you, I've got 4 or 5 patients I'm talking after months of trying mood stabilizers and every other kind of medication and different amino acids and changing the diet and psychotherapy are just, you know, they're just not going to do it. And even they're on buprenorphine, it doesn't do it. Then I will use a very low dose of a very long-acting benzo under extremely controlled circumstances. And that works quite well for some of them. So honestly, I don't think that seeing people that have anxiety. Now, the anxiety may be caused by the fact that they are in drug withdrawal, or that, you know, they have got, their brain has been altered so much by being on whatever they were on that now they've got a serious anxiety problem that buprenorphine isn't strong enough to treat on its own, so to speak.
Okay, great. Thank you so much. And that's all of the time we have for questions today. We do have some final instructions regarding CE credit. And again, should you have any issues with this process, do not reach out to today's sponsor, as they will not be able to assist you in receiving a certificate. To receive your certificate for today's program, you must click the green Program Evaluation widget, complete the evaluation form, and click Submit. A special note for today's program is that Addiction Professional will be emailing out their certificates within 48 hours, and one will not automatically generate for you at this time. We do thank you for your patience in this matter. For those watching in a group, as a reminder, please download the group submission guide and program evaluation located in the resources area and follow the instructions provided. For those watching from a mobile device or tablet, you will need to email the help desk to receive a program evaluation and certificate for this program. Please note that CE credit is not available for the archived webinar and only for today's live event. If you have any questions, please click the purple Contact Webinar Help Desk widget at the bottom of the screen. On Thursday, October 29, 2015 at 1 p.m. Eastern Time, please join us for another addiction professional webinar sponsored by Foundations Recovery Network along with Millennium Health, titled Components of a Successful Long-Term Recovery Program, presented by Ken Seeley, who is featured on the Emmy Award-winning and 2015 Emmy-nominated A&E television series Intervention. A link will appear on your screen in a moment for you to register for that program. You can also register for the event by clicking the purple Register for the Next AP Webinar Sponsored by Foundations widget at the bottom of the screen. I want to again thank Richard Gracer for an excellent presentation. I also would like to thank Millennium Health for making today's Foundations Recovery Network program possible. Finally, thank you to those in our audience for participating today. We hope you'll join us in the future for another Addiction Professional webinar, and this concludes today's presentation.